So what will this test case, if you like, mean for the rest of the world, including Australia? Well, joining me live is infectious diseases paediatrician Professor Robert Booy. Thanks for your time. It's obviously a different situation to us. They have a higher vaccination rate, albeit well off the sort of one we'll probably open up at. But what can we learn from what is about to happen in the UK right now?
Oh, we're learning a great deal from the UK. They've experienced so much more disease and death, 130,000 deaths. We've got under 1,000. They also have got Delta causing a lot of trouble, mainly in younger people, younger adults and children, but it's less severe. And so we're seeing fewer children by comparison with adults being admitted to hospital for Delta. So we're learning a lot from them. They're trying to show us how to live with the virus. We're not sure we want to do that just yet. We're so good at controlling it that we don't need to live with it. But if it ever got out of control, we'd learn how to live with it the way they have. But that's at a cost. So although we can learn from them, we don't want to emulate them.
So they're living with it. We will at some stage. It's all about those parameters, and they're doing it at what will end up being maybe a double dose vaccination rate if it really surges in sort of the 60s. We'll end up doing that a lot higher. So again, the sort of parallels we can take, is this something that we can go, well, here's a real world example, here's how much higher we need to get? Is that too simple to say?
Look, we're learning from all sorts of countries, not just the UK, but also the US, Canada, Taiwan. Taiwan's got the same population as us, and it's had so few deaths until recently. They suddenly had a Delta surge that lasted about 6 or 7 weeks, and 500 or 600 people died. So we're learning from them. They clamped down, and in 5 or 6 weeks, they got on control of it again. Now, Taiwan controlled Delta within 6 weeks with a lower vaccination rate than us, but with very strong infection control, social distancing, things like that. So they give us an example of a nearby country who has controlled Delta and got it back down again after about 6 weeks. So we're learning from the UK, we certainly are. They have treated so many people who've been sick and saved their lives with new treatments. We're learning from the level at which you might be able to open up. The best guess we have right now before the modelling comes out is about 60%. When Daniel Andrews says, 25% of the people might not be vaccinated, well, if they're all children under the age of 16, well, they hardly get severe disease. Of course, the occasional one gets severe disease, but as a paediatrician, I know from working with colleagues in the UK and speaking to them that they're not being overwhelmed in their intensive care units with children with COVID. For every one child who dies of COVID in a rich country like the UK or the US, 500 to 1,000 deaths occur in adults. So we need to prioritise the adults getting vaccinated and worry about children later.
So Daniel Andrews did make this comment this morning you alluded to, that if 75% are vaccinated, 25% won't be, and that would overwhelm our ICUs within our hospitals. What's your view on that? I mean, yeah, the way I'll phrase that though, if he's talking about 75% of our people aged over 16, could that be true or would that still be untrue?
Well, two facts. First of all, about 25% of the population in Australia is under 16. If he's talking about getting 75% of people over 16 vaccinated, that's a good level to aim for. I don't think it's good enough, but it's a good start. We probably need to have 80 to 85% of people over 16 to be vaccinated to get the likelihood of herd immunity. This virus is mutating, and so virus mutations lead to partial escape from our immunity. So we have to factor that in, and that's why we're looking more and more at a much higher rate of immunisation for people over 16 to get herd immunity. But even before we get to herd immunity, we can have a situation where there are occasional outbreaks that are short and small in number. That's not perfect protection, but it's a lot better than overwhelming the health system. And I think along the way to getting 80 to 85% protected, we can achieve 60, 65, 70, and at that we'll start to see real improvement in outbreak control.
You mentioned as well the outcomes for children in the UK. Just to clarify what you were saying, so what we're seeing so far is comparing Delta to previous variants, it actually seems like there's a lower percentage of those that get the virus that end up seriously ill. Is that what you're saying, and how sort of solid is this data?
I don't feel I need to labour that point. What I'm saying is that whether you got Wuhan or Alpha strain or Delta strain in children, it tends to be less severe and it tends to transmit less between children and from children to adults. We're finding that often when children get infected, they're getting it from their parents, from people in the community, from adults. So it's an unnecessary argument to say whether Delta is more or less severe in children than Alpha. They're both unpleasant, but in children, the likelihood of hospitalisation is much lower than it is for an adult, and it's certainly much lower risk of death as well. And it's what I call a double truth. You can get very sick, but in a minority, a small minority. The great majority of children cope very well with COVID infection. That's the second truth.
Interested in your view on ATAGI, because there was some speculation perhaps it would change its advice or the strength of it, whatever it might be, on age groups getting AstraZeneca, given the outbreak in Sydney and some of the younger people there already in ICU. What was your view on ATAGI leaving this the same? We've got the AZ shots there ready to go, but not a lot of them are going to get into the arms, in particular of the under 40s, it seems.
Look, I trust ATAGI. I respect them very much. I know many of them. They're really smart people. They're making decisions collectively with a lot of discussion and debate. They're making good decisions. We don't want to see them jumping about every couple of weeks with yet another decision this way or that. We always knew that AstraZeneca was licensed and could be used for people from 18 years of age and above. They did produce one statement saying it was probably better to keep it to above 50 and then above 60. Well, quite honestly, I'm in my 50s. I had AstraZeneca, and after all the hullabaloo, I still was happy to have a second AstraZeneca because the evidence is that a clot may occur, but at what we call very rare, around 1 in 100,000. And we're so good now at diagnosing and treating it, the risk of dying from a clot if you get a vaccine in your 50s like me, again, by AstraZeneca vaccine, less than 1 in a million. So you're more likely to get hit by lightning. And who's been hit by lightning?
It's a good point to end on, because it has been something that initially had a higher chance of dying, but the treatment and identification has been crucial. Professor Robert Booy, thanks for your time today.
Pleasure.